Hello everyone, I am Dr. Sandhya, consultant obstetrician and gynecologist practicing at Cloud9 Hospital, Sarjapur Road, Bangalore. Any patient in labor can have fetal distress. Fetal distress usually happens when there is reduced oxygen supply to the fetus during the process of labor. So how do we identify if there is a fetal distress which is set in? When the patient is in labor, usually we monitor them with a cardiotocograph. So these continuous heartbeat tracings will usually tell us if there is any distress which is going on. So there might be decelerations or there might be heart rate variations. The heart rate may be too less, which is referred to as bradycardia, or heart rate may be too rapid, which is referred to as fetal tachycardia. And sometimes there can be a situation where the baby has already passed motion inside, which we refer to as meconium-stained liquor. In certain cases, especially in a patient who has had preeclampsia, there is always a possibility of increased uterine contraction and sudden fresh vaginal bleeding, in which cases we usually suspect premature separation of the placenta, which is referred to as abruptio placenta, and very rare possibilities cord prolapse can also set in, and these are the common causes of fetal distress, usually what we see during process of labor. How do we prevent fetal distress? So it is always better that we anticipate the cases which can land up in fetal distress and be well prepared for such a situation. So we can always prevent fetal distress by continuous fetal heart rate monitoring, wherein any heart rate variations can be picked up as early as possible and immediate treatment can be given. And we have to hydrate the patient well, and well hydration usually reduces severe form of the distress to set in. And once the patient is in labor, some nurse or somebody has to be there by her side to constantly keep a close watch on the fetal heart rate as such. Any deviations from the normal has to be brought to the notice of the doctor as immediately as possible. And having said this, there are certain patients who are more prone for fetal distress when they get into labor, and in such cases we will usually be more vigilant in identifying, and then correct action can be taken if the diagnosis is done immediately. So these patients will be, if there is a cord around the neck on scan and when the patient is induced labor or she gets into a natural process of labor, they are at more chances of developing distress during the process of labor. And in some cases, if the fluid level is less, which we refer to as oligohydramnios, or if there is a growth restricted fetus which we are trying for a vaginal delivery, such babies also can have distress eventually. Patients with a big baby, especially in cases of gestational diabetes mellitus, or a patient with preeclampsia, and other cases, in case if we are allowing for vaginal birth after cesarean section, also the chance of fetal distress is little on the higher side. So any such patients who are in the labor ward need to be closely monitored, and then appropriate action needs to be taken on time. So once we have diagnosed that there is a fetal distress, what are the further measures that we take to prevent or reduce the distress till we deliver the baby? So once the distress is diagnosed, we usually stop the oxytocin drip. If the patient is on oxytocin, we turn the patient to left lateral position. We make sure we hydrate the patient well, and we also inform the OT, anaesthetist and neonatologist that patient is having fetal distress and the delivery is likely to be possible. Once the distress is diagnosed, within 30 minutes we make sure that the baby is delivered. Sometimes the patient would have progressed to a second stage and they'll be ready to deliver vaginally. Again, to reduce the further distress and further effects of reduced oxygen on the fetus, we'll cut short the second stage of labor by considering the instrumental delivery, which may be either by vacuum or forceps.